Good morning, everyone. I'm Deepak Bora, Head of Marketing for Invencia team. So, in yet another enriching session of Meet the Expert, we are really privileged to help us continue our journey of making India iron strong and propagate the uses of injectable iron. Once again, we have one of the top most gynecologists of the country, Dr. Kavita Bapat from Indore. She needs no introduction. Everyone knows Dr. Kavita Bapat, especially in our family, since our team is totally dedicated to gynecologists. So here, today we are hoping we will have one of the most enriching session with regard to learning the real life scenario and usage of injectable iron, particularly FCM, with none other than Dr. Kavita Bapat, who herself has used for so many years, and she has the kind of knowledge as well as experience which no one can match. So, with this, my colleague Nakul will take us through this enriching journey. So, over to you, Nakul. Thank you, Nakul.
Thank you, Deepak
Thank you,
sir.
man.
Thank you very much. Yeah. Very good morning, all. I welcome to all Acute Cluster team, which includes Pharma, Invencia, Zenex, IVA team, to this scientific Meet the Expert webinar. I'm Nakul Patil, Senior Product Manager, and we are aware that we are Emcure. We are the purpose-driven organization dedicated towards offering effective medicine to cure the patients. And we at Acute Cluster having the FCM franchisee with epitome of quality and success. Till Emcure has helped more than 60 lakh Indian patients to rapidly correct the iron deficiency anemia, and we have taken a pledge to pledge for the making India iron strong. And rightly Deepak sir said that today MQ is very honored to have esteemed speaker Dr. Kavita Bapat, and we are thankful to Dr. Kavita Bapat for giving us opportunity to host this scientific Meet the Expert program. Definitely, today's Dr. Kavita Bapat sharing her views on real life scenario of usage of FCM, and very importantly, I want to highlight one thing over here to all delegates who's attending this webinar. Surely, definitely, our expert going to address whatever the questions, whatever the doubts you are having. Please put in your chat box. Definitely, she's going to address. Once again, I welcome Dr. Kavita Bapat, and over to you, Doctor.
Thank you so much. Thank you so much. I'm incredibly grateful, Malum. The help you have all provided me, and I cannot express with the words how thankful I am to the Emcure that all the generosity and the assistance all of you have given to me. Really, really, I'm so thankful. And I want to take a moment to express really the sincerest appreciation of this. So today being the topic given, and the topic is, but I like to share screen so that we can talk and we can discuss on this point. So I'm sharing my screen. Am I visible? My screen is visible?
Visible.
Yeah, thank you so much. So we'll talk, everybody knows, all of you are working so hard and you all are knowing the subject much more than me probably, but the insight which I feel, I travel a lot, and what the gynecologists all over India, what they exactly want and what they are happy when they listen this type of presentation. So this is a little presentation and we can discuss, and all the question answers which we can do afterwards also. So happy to be from Indore and all the points. Now, just talking about all these things are like, what's the prevalence of in India anemia is. See, I am practicing for last 32, 34 years in OBGYN. And when I was a student, anemia was there. Today, I am a senior practitioner since anemia is still there. So why we are lacking, or where we are and why we are not able to eradicate or eliminate or decrease the incidence of anemia, why we are lacking. That's very, very important. And the worldwide, so much living in this 1620 million people are living with anemia. and it's anemia during pregnancy. And so global is 56.4 million pregnant women all over the world. And our incidence in India is almost 52.2%. So again, where we call to whom we say that it's a hemoglobin level, that's a WHO says the anemia is less than 11, mild is 10 to 10.9, moderate 7 to 9.9, and severe is less than 7. And these are the anemia mukta guidelines, WHO definitions of anemia. Common causes, let's discuss it about in a more major headings. Number one, either there is a decreased iron absorption, or there is a decreased iron intake, or there is an increased iron demand, or there is a blood loss. If four things are kept in a mind, we can talk about the common causes of iron deficiency and anemia. And absorption may be celiac disease, malabsorption, chronic inflammatory disease or the malignant disease is there, and the concomitant intake of iron is less. Or increased iron demand, which especially we are insisting and talking about all over India. This point is very, very important, especially into the pregnancy and lactation, especially during infancy, adolescence, and endurance sports. Then the why in decreased iron intake, vegetarian or otherwise, not too much with the unbalanced diet, eating disorders, and disease-related anorexia. Blood loss is another important point. I am using FCM. Most of my patients, which I am using the FCM, is probably for the AUB and the before the surgery, because I am known for the surgery. So the heavy and the prolonged menstrual bleeding, delivery is one of the things, gastrointestinal bleeding, and surgery and blood donation. So blood loss, and we have to replace, that's important. So how much iron is required? It's this is very, very important. All the Western diet 1 to 5 milligram, and the Indian diet is very less. So that's the big problem. So what are the consequences? Why we are talking all the time iron deficiency, anemia, and pregnancy? See that by 2030, the SDG goal says that we have to reduce the maternal mortality to bring it into 2 digits. Probably we are very happy and lucky that we have already reached nowadays. And it's all the efforts of all the obstetricians and gynecologists of this country that they have worked hard to reduce the maternal mortality of this country. And basically, anemia is one of the major reasons for the maternal mortality, because if the anemia is there, then the chances of having maternal mortality, morbidity are more. And these are the consequences: antepartum complications, there is a risk of preterm delivery, chronic placental insufficiency, premature rupture of the membranes, preeclampsia. This is another big chapter. Then intercurrent infections. If the patient is anemic, more chances of infection. There are antepartum hemorrhage. Again, the patient is anemic. Small BP, small blood loss will lead to trouble them more. And the congestive heart failure. The fetal outcomes are very, very important. See, if the anemic mother is delivering with the babies which are not healthy, that will trouble our nation in future. We need a healthy nation, healthy mother, and healthy babies. So the low birth rate is another problem. Prematurity is problem. Spontaneous abortion because of anemia is very, very important. Fetal death, which we are not able to say that why the baby died into the uterus, is one of the reasons is anemia is one there. Infections because of anemia. Congenital malformation because the content of the iron is not good and the problem becomes. Then the neonatal anemia. If the mother is not okay with the anemia is there, the chances of neonatal anemia. The babies are growth retarded, and most important, abnormal cognitive development. This is a future of this country. A patient can come and sue the gynecologist. 25 years boy or an adult can come and say that you have not treated my mother during when she was pregnant, and my mother was anemic that time, and now my IQ is low. So these are the consequences we should be care of and thought about. So maternal anemia contributes 18% of perinatal mortality and 20% of maternal mortality in our countries like India. Now, very simple. Is it not a rocket science that we are talking about? How to talk about the diagnosis of iron deficiency anemia? History is very, very important. Simple CBC will give the indication of iron deficiency anemia. We have to do 2 things, MCV and RDW. Iron deficiency anemia characterized by low MCP, low MCH, and elevated RDW. So simple thing, by simple seeing the CBC, We can come, not only the hemoglobin is not only thing, low hemoglobin always there, but hemoglobin low and iron deficiency anemia, these two things we should consider, that low MCV, low MCH and elevated RDW is there. Why we are worried about RDW? Because we have to differentiate if the patient is hemoglobin is 7, and the low MCV, low MCH and elevated RDW, we'll say this is iron deficiency anemia. But the low MCV, low MCH and the decreased RDW, it says she's having thalassemia. Very simple. So find it out. Serum iron and TIBC are unreliable markers and we should not be worried about. And pregnancy itself increases the total iron binding capacity even in the absence of iron deficiency anemia. So the two things, MCV, MCH and elevated RDW is very, very important. Serum ferritin, again, it's a costly test, not to be done. See, this is not a point to talk about this. We are talking about the country we can reach. We have the same standards for the affluent patient, and we should have the same standards for the poor patient. So if we should have the same thinking about anything. So we can diagnose the iron deficiency anemia. Why we have to test serum ferritin? When only in those cases when the patient is hemoglobinopathy. And these patients, we are giving the parenteral iron therapy. We need sometimes to give the serum ferritin to be tested. And there can be alternate etiology of microcytic anemia is being inflammation, sideroblastic anemia. An increased risk of iron depletion, as we know, previous anemia. Then we can have a multiple pregnancy, teenage pregnancy, and all those things are there. Bleeding, high risk of bleeding and consecutive pregnancy in the Emcure. Now we come to the iron. Which iron is the best? Dietary iron, I'm not going into it because I am not a master to talk about what kitna gehu, kitna atta, kitna chawal, whatever to take. Oral iron is important and a parenteral iron. Now the problem with oral iron and how we are taking the oral iron is definitely a good. I'm telling you, it's not a bad, but when to take and when not to take is a question. Oral iron supplements have iron either bivalent or trivalent. See, all our life we are worried bivalent day or trivalent day, ferrous, fumarate. There are so much are there. There is ascorbate also, fumarate also, sulfate also, biglycinate also. But the trivalent can be a polymaltose complex or the ammonium citrate. At any day, absorption of the ferrous iron is 3 times higher than the ferric iron. So the bivalent are good when we take the oral one. But the limitations of oral iron are there. Sometimes the absorption is poor. Sometimes if the patient is taking medications or something, food intake, sometimes that is inflammations. Then sometimes mother took months to correct the anemia and replenish the iron stores. And the main issue with the oral iron therapy is reduced because of the gastrointestinal side effects, bloating, diarrhea, heartburn, nausea, constipation. And oral iron requires comparatively longer time to rectify anemia and restore the iron stores. So the country like India, where we have a patient with a 32 weeks of pregnancy and 8 grams of hemoglobin, oral iron will not work because we want to save the mother, we want to save the baby, and we have to reduce the maternal mortality and morbidity. At that time, we believe it is not sufficient for the moderate to severe anemia and the late second and the third trimester. So the role of parenteral iron comes, why and where we are. The indication number 1 is the failure of oral iron therapy, non-compliance, late second and third stage moderate to severe anemia, if there is a malabsorption, if there is a hemorrhage, if there is a combination with a recombinant erythropoietin patients with a pregnancy and a chronic disease, and a moderate to severe postpartum anemia where compliance of oral iron and follow-up to the health is doubtful. So, but there are contraindications also if there is a facilities to resuscitation, known history of anaphylaxis, and gestational period should be more than 12 weeks. So this is a simple parenteral iron preparation. This is the IV iron agents, spheroidal particles. There is an iron inside and outside there is a carbohydrate shell. A very simple to understand. And these are the 4 types of iron, which are the parenteral ones. When we were students at that time, iron dextran was very, very popular and there was a great risk of anaphylaxis. We have seen patients dying because of iron injection, because of anaphylaxis with iron dextran, and so much problem are there. Then I am so happy that the government of India is doing so much with iron sucrose, multiple doses, longer time of administration, but it doesn't need the change of the thing. Then the FCM, we all of us know that's how much popularity and how much important and how much doing good that FCM is. It's because we are getting the high amount of iron in a single dose and a very, very low risk of hypersensitivity. In a competition with this, there is an iron isomaltoside also, but it contains, number one is a dextran, number two, more liable iron compared to FCM, but they have the very less number of design studies in a different indications. So the chances of giving is a comparison between the two is definitely there. Now, what properties a parental iron should have and what property FCM is having. So I always feel good when we talk upon somebody's ideal, that this person is ideal. And we have 10 things to know, and which is very close to ideal is basically the ideal. So for example, the ideal one, the molecular weight should be more than 1000. And definitely FCM is having 150. Complex stability, it should have high. Same with the FCM, it is high. Half-life, long. We need a half-life should be long. So 16 hours is a good hour time. Again, pH neutral for the ideal, and FCM we need, it's a very near not neutral. Osmolality, it should be isotonic. The FCM is also having isotonic. Antigenicity, that's another important point. We don't want any antigenic to causes the things. So it's low with the ideal, and it's with FCM, it's also low. Test dose, another important point. We want to promote the parental iron with. The test dose is not required, and same with the FCM. And time of injection. Nobody is having much time in life, even today, that you have taken out the time to listen to me. So we don't have much time otherwise also. So ideal is a very short, and FCM, we all know it's only 15 minutes for the 1000 milligrams. Another important point. And maximum dose for the infusion, 1000 milligram in infusion, it's very, very high, can be given. So these are the qualities of FCM. All of us know it's a robust. It's not associated with the induced hypersensitivity. Can be administered with much higher dose, short infusion time, very, very important. It's iron released slowly, avoiding toxicity and oxidative stress, and structure similar to ferritin, deposit easily into the retrocolon endothelial cells. Test dose not required, and low immunologic potential. So what should be the dose, how it has to be given, and how has to be taught about? Hemoglobin less than 10, it depends upon the body weight. If the below 35, 500 and 75, 11, we can give up to 2 grams or the 2000 milligrams. Hemoglobin 10 to 14, again 500 to 1500 and more than 14, though we don't talk about it, but 500 milligram can be given comfortably. So it should be given if the dose 215 ml, 15 minutes should be given. And if the dose is more than this minimal administration time, and that's the point. If it is given only the 500 gram, the 100 milligram is good. The important point, if it is given more than 15 minutes, the chances of chelation over there, chances of reaction over there. So precisely 250 ml, 15 minutes for the 1000 is a perfect for giving the iron. Now the evidences, so many evidences are there. I'm not going into detail of it. There are several studies, several points are there that suggest that the FCM is the best into the world. And that's not so important. They are there, and we are considering all the studies should be in a proper manner. There are Indian studies also, and they have done to control trials, and there is definitely the rise of hemoglobin in 12 weeks from the baseline. They have say include up to 3 grams of hemoglobin. Good studies about the neonatal anemia and Apgar score also. That's also very, very important. So the newborn, what is the gestational area, the delivery, mean birth weight, Apgar score, stillbirth, perinatal, early natal mortality rates, all are important. So these are many, many outcomes are also important. And this is the line, which is anemia mukta Bharat, what this is. Severe anemia, 5 to 6.9, first level of treatment, immediate hospitalization. And if it is third trimester of the pregnancy with around the clock specialist care is available, treatment will be done with IV iron FCM by the medical officer. Now, these are the summary, the timely detection and appropriate treatment of iron deficiency anemia, improve the maternal health and pregnancy outcome. FCM administration requires no test dose. Duration of the dose administration is short, not associated with hypersensitivity. Most studied parental iron preparation and has safety database available. valuable alternative for the pregnant women who lack to response to non-compliant and intolerant to iron treatment. Single dose administration, rapid rise of hemoglobin, favorable safety profile with no adverse effects, no serious adverse effects. It's preferable option into moderate to anemia. And during the second and third trimester, it's well tolerated and it's very, very important. Thank you so much. I think I've stopped the sharing the screen so we can have the question answers on it. Hello?
Yeah, ma'am, we can hear you.
Yeah.
It was wonderful, shortly you did, and that was we are expecting from this session, ma'am. Actually wanted to ask a few questions, ma'am.
Yeah.
My first question, ma'am, what is your protocol for selection of IV iron therapy? Means which criteria you follow?
For me, you say to whom I give it. I divide the two types of things over here. First is for the pregnant patients, and then the non-pregnant patients are there also there. First, I'll talk about the non-pregnant patients, and then I'll talk about the pregnant patient. See, the patients come to me for the surgery, and their hemoglobin is, for example, you can say 10 or 11, this thing. And they come with the AUB. So they are basically, though their hemoglobin is 10, but they have the store of iron into this thing. So doing surgery, if I want to get them heal well, or you can say the blessed hospitalization time, and they should be perfect or the good health as early as possible, I prefer to give this FCM to all those patients, even they are having the hemoglobin of 10, 11, 12 even, because sometimes low MCV, low MCH and RDW, which is very, very important for me, or even for because iron deficiency is more important for me than the hemoglobin anemic, but the hemoglobin should be less. And you can understand, so this is one criteria I give just pre-operatively or sometimes post-operatively. Now in the cases of anemia, it's protocol over my place that each and every patient at least 1 or 2 times they should be get the parenteral iron after the 20 weeks of pregnancy, not before that. We can give them between the 12 to 20 weeks of pregnancy, but we prefer to give it after 20 weeks to make ourselves safe. And very specifically and they themselves come and ask, Madam, humko parenteral iron kyun nahi laga? So that's another important point. And that gives the strength to myself. That's the reason. And same thing, hemoglobin, instead of hemoglobin, I just believe more on the deficiency of iron rather than putting 7 gram, 8 gram, 9 gram. That's more important for me.
Ma'am, right. And what about the, you said rightly, HB level and in pregnancy. Is there any criteria, body weight criteria?
And definitely, we always have the body. Without body weight criteria, we cannot think about it. If the patient is less than 35 kg or between the 35 to 40, 60 kg and again 60 kg and above, it depends upon that. That is really important to calculate the dose for this. And if the patient is more than 60, 65 kg, we can give up to 2000.
Correct, ma'am. Ma'am, rightly you mentioned that the government of India, they recommended FCM as a first line of treatment who are the pregnant and detected anemia in late pregnancy. So means what precautions you take in second as well as in third trimester while giving FCM?
See, this is the world of litigation. We should be very careful. Giving iron is good, but the OBGYN should give at least 5 to 7 to 10 minutes to counsel the patient that we are giving you iron. Am I right? And the person who is trained of giving iron, not always we need the intensivist or we need some hospital thing or over there, but at least the person who is sitting close to the patient who is given, we are giving the iron, they should be the nursing staff or the, whatever you can say, a trained staff or a duty doctor, whatever it is, we need to be around that. So it's only the job of 15 minutes. Good counseling is very, very important what we are going to. It should be 15 means 15 because we are worried that if we are not giving more than this like that. So the number one is counseling. Number two is a correct dose counting. Number three is a proper IV, this thing. And the duration is very, very important. 15 minutes, start a watch. Make a duty doctor or somebody who looks after the things should be there, and take a BP first and take a BP afterwards. And don't allow the patient to go or leave the premises for at least next 45 minutes. So it's a total 1 hour job. It's not like that injection laga or ghar, they allow them to go. See, this is very important. Anything happens, there we are there. So 45 minutes, though we are very happy with FCM that we don't see the hypersensitivity, we don't see the reaction, we don't have the external problem. Still, 15 minutes and a good staff around it, and should be given in proper duration.
Right, doctor.
Ma'am, one question. As in the severe anemia, the causes are mostly the multifactorial. Maybe the underlying cause, vitamin B9, B12 deficiency. So should we give another supplements like B9, B12, or any dietary advice, or plus injectable iron plus oral iron therapy? What do you advise in severe type of anemia? Any investigations also?
Basically, as a being a senior gynecologist, you can say, or obstetrician for the longer time, we can say, or anybody. We are not treating ek cheez treat nahi karte. We are there to treat overall comprehensive health we are worried about. It's not like iron deficiency and the I've given the iron and I'm done. No, it's not for them. We need them to supplement with protein powders. We have to give the multivitamins. We have to talk about the. We can make a big list, but we should be precise, because only giving iron, how it is going to end the thing. We have to be a comprehensive. We should be precise, and we should be very much a good follow is very, very important. I think it's a basket is to be offered and to be given.
Right, doctor. Ma'am, rightly you mentioned in your presentation that whatever the isomaltoside has the more labile iron.
Yeah.
Labile iron, which cause the reactions, but we could see still many doctors, they are using isomaltoside. So dextran also has, isomaltoside also has more labile iron. So what you can say about that?
To impress that more labile iron will increase the more hemoglobin, maybe like that. But what I feel, the FCM molecule is such, no, that under iron is there and surrounding is there is a thing.
Yeah.
It's a very sustained release of type of release of iron is over there. You try to understand it, which is 15 minutes. After the 15 minutes, it just burst out and suddenly they're too much. So we want a labile iron to be there, but they should be in a proper, slowly manner, they should work on it. Having a too much iron, the reticuloendothelium is not going to take it. Then what's the use of having more labile iron into the circulation? Jitna chahiye, wo gradually chahiye, slow release mein chahiye, and the way they should have.
Sir, doctor, one question from Sandeep Chandran. In patient, if HB is 11 and she is an AUB, but the CBC and ferritin is normal, what is your treatment? What will be the treatment for this patient?
CBC is normal, hemoglobin is also normal.
Yes, sir. CBC and ferritin is normal.
Yeah.
And hemoglobin
having
is
AUB.
and
yeah, and
hemoglobin
hemoglobin.
reading she has.
AUB mein hemoglobin kitna hai? What is the hemoglobin?
Hemoglobin is 11.
11. See, I always believe that the honest word and that unnecessary administration of any drugs are bad. But see, 11 is such a basic point. If I'm doing surgery and there is a great blood loss, chances of a loss during surgery, though it's very less during the surgery childhood. But if we think there is a great loss is going to happen, and if we are giving the FCM just after the surgery, it will help her to become normal, or she will be recover very fast if her hemoglobin, if we have given the iron just post surgery. Because sometimes before surgery, the hemoglobin is less, But if immediately we'll do after 24 hours, the hemoglobin, it may be 9, it may be 8, it may be 10. So given iron to them will also help them to recover early and fast.
Correct, ma'am. Absolutely. And ferritin evaluation is also important.
I need not to be worried about the ferritin level, need not to be worried about the iron stores or anything. The hemoglobin is 11 and we are going to do the surgery. We are thinking that there is a blood loss is more. Post-operatively giving the FCM have really made me happy because patient recovers very nicely and she comes up with a strength after 7 days. Otherwise, we have to give her for the 3 months iron dose and again the gradual recovery and not happy with all other things, more chances of infection, more chances of the worst life. So it's better to give the iron post-operatively in the patients with a hemoglobin of 10, 11, 9. It's good.
Absolutely. Yeah, ma'am. Next question. Many questions I could see over here. Question from Mr. Sridhar Kumar. He is asking, can we promote FCM in below indications like restless leg syndrome, IUGR, preterm anemia, and stillbirth?
Stillbirth, I think is a really good point to talk about. So the 26 to 28% patients having a stillbirth, there is no reason for it. What they say is a non-indication, there is no etiology for the 26% of the patients with a stillbirth. So and stillbirth is one of the, can be the reason because of the anemia. So the prematurity, all the points which we have talked about the fetal anemia, all the IUGR, all the stillbirths, these patients we can save. This type of problems we can save if we have given the parenteral iron. There is definitely, I think, so many studies are over there also because there is an increased Emcure score, the gestational age improved, the fetal weight improved, the fetal anemia improved. So these are the points.
And what about, ma'am, IUGR?
Again, same with the IUGR. See, other causes of IUGR may be there. Sometimes the polyhydramnios, the oligohydramnios, if there is a placental insufficiency, everybody is correlated with the anemia. If the patient's anemia is good, many more things improve. So at the end of the day, we need a good hemoglobin level, good oxygen supply to the baby. IUGR, though, it's a direct relation with anemia. So giving and treating anemia is perfect.
Dr. Nishikant, any question from your side? There is one question, ma'am, from Mukesh Pandey. He's from Pharma
So,
Division. And he's
as you said,
asking, just Dr. Nishikant, he is asking when to start oral therapy after FCM infusion. What is the right time to start oral therapy after giving that FCM, ma'am?
Really, we need much more to study upon. Sometimes people, they don't stop oral iron supplementation and still they give the iron infusions. It's a question, but at least we wait for 3 weeks, see the condition and then start it, the oral iron therapy. It's my protocol. Iron the iron, because the patient is already of those type, no, their compliance is not good. That's why we are giving the iron. Otherwise, they would have eaten the iron properly. Why their hemoglobin would have been that low? Am I right? They are not taking, there is so many problems. There's an indication because the iron oral compliance is bad. That's why they take it. So after giving oral iron, we can start very next day. There's no issue of writing the oral therapy on the next day. And we can also start. That's no issue. But logistically, we should wait at least. But I think it's in heart of heart, we can start the oral iron therapy next year also.
Right. Yes, Dr. Nishikant.
So as you say, in the major surgery, especially the vaginal hysterectomy, for example, so you advise every patient post-operatively to take a injectable iron or
it's in my protocol. It's in my protocol. Even the Apollo hospitals where I do the surgeries, they immediately ask me, "Madam, isko iron laga dega." So I think it's a protocol. It makes me happy, and I have told you the compliance and the recovery is good.
Yeah.
I need all help of you people that we can have a good study on it.
especially after the major surgeries,
Yeah,
C-section
yeah.
and hysterectomy. And
Yeah. We need a good study.
One important point, that's a key. How iron infusion better than blood transfusion? Can you elaborate, ma'am?
Yeah, and there's, I think the nice guidelines also are there over there. No, they have given it. How many problems are there with the giving the blood transfusion? You can yourself imagine, though it overall increases the health of the patient, but all the reactions, all the problems, all the regulations, all where to give blood transfusion, we cannot give anywhere. No, the iron transfusion, the FCM we can give at the hospitals, at the small places, and to get blood is also not fun. And it's not a day's job. See, I have seen a patient who survived from 110 things of doing surgery, but she died of the blood transfusion reaction. So, so where we are, so blood transfusion is horrible at the any day. Jahan blood chahiye, definitely we need blood. But if we can, jahan blood nahi chahiye, so we can think of.
despite having cross matching and blood group matching, there are a lot of reactions happening.
So many issues, the infusion, the timing, the how to do it, how to get the blood available, what compatibility it is, what the reaction it has, so much big protocol it has. Am I right? And where it is needed, it is definitely, the hemoglobin is 6 gram, what I am doing to with the parenteral iron. Am I right? But if the patient is 7 gram, 8 gram, 9 gram, where I can use iron than this. And the cost is not the point for this. I'm telling you, this cost is not the issue, is the health is issue, which is priority. We should not talk about the cost. What is our priority that's more important than the cost in anything in life?
Ma'am, from the field perspective, just I want to know that what, as a gynecologist, what you expect from the field force to discuss with you?
I know. You just let me know what they want to ask me. And what I want support. That's all.
In terms of clinic, like when they come to, in terms of the behavior, knowledge, what is, as a
Achha, you are
gynecologist,
asking
what
that.
is your
Okay.
expectation?
Okay, I'm sorry. Yeah. When they enter into the room, what they should talk to the consultant like that? What do you want?
Yeah.
They themselves, honestly, they themselves should be assured what they are talking. Am I right? If you are confident about your own product, you will put the product properly. If I'm confident about myself, I'll put my product properly. That's my way of putting things.
Maybe the protocol, the how to manage the anemia, mild, moderate, and
They should
severe.
know. They should know each and everything, and they should be able to talk about. They should be really confident about their product. Am I right? Yeah. खुद ही confident नहीं है तो फिर क्या ही? There's no issue.
Because some of the doctors already know how much to give.
Yeah,
maybe
everyone
some
knows.
doctors.
Nowadays, everybody knows.
Yeah,
Most of them know. It's only the top of the cherry, how the results are, what the results are, and how the FCM is doing good and better. That's important to talk about, I think.
But ma'am, we could see many gynecologists, they are the non-prescriber for the FCM due to some reasons. I could say the prescriber best. There is a very low, few gynec, they are having fear. So what top 2 points we need to highlight to that particular gynecologist?
Fear.
About FCM.
I know. Here is, you have a tremendous data, am I right?
Yeah.
They are educated people, they'll understand what is going on. Initially, they were worried about the cost. Now they were worried about some issues. But the proper feeding of the data, proper genuine request, I think, will always be the proper way. Because you have, it's not like that, no? You have sufficient Indian data you have now. It's not that you are talking about some international data about. And I think all over India, this product is doing extremely
Right.
Ma'am, one
Suppose,
thing.
ma'am, if lower dose of FCM is available, that it will be helpful.
I think Yeah, it will be. It will work. Because हमारे यहाँ ज़्यादा weight antenatal patients का कुछ भी ना overall coverage देखा जाए, so it's not there. And the low dose, another is important point is, and it will help them in the cost also. Yeah, 750 will work.
Right, ma'am.
But the minimum is always 500 or 750. The minimum amount has to be,
The choices will be more probably.
okay.
The doctor will have more choices to offer.
Also, some of the doctors they insist to have a taste dose. So what to advise for them?
Test dose.
Taste
Taste
dose. They want to give.
Again, they want to give is their issue. But you don't need it, you have to tell them, I tell you. Because it's not needed, no? Test dose is not needed.
Maybe the 4 to 5 drops, then wait for 5 minutes and rest of the infusion in another 15-20 minutes. That will help.
Do you have any study regarding this कि किसी का test dose किया तो ये हुआ और जिसको test dose नहीं किया तो ये हुआ?
No.
How can you put it? It should be authentic and evidence-based things, no?
Okay.
What your evidence talk about? Test dose is not needed, means not needed.
Okay. Yeah.
It's not a homeopathy, it's a science.
Some doctors insist, can we give?
It's there, it's
Yeah.
there only, you know.
Hmm.
But what evidence talk about? You talk about that. Do you have that study? कि किसको test dose किया?
No, but some doctors says we have to give 5 to 10 drops. And
I'm
wait.
talking about the company has
No.
done some studies or they have a studies over test dose.
No.
And how we can talk about सब कुछ मुंह से पिला के देख लेंगे. People can talk anything. What you should talk should be very scientific.
Right, doctor, right. Doctor, one important question from audience. Yes, Mr. Deepak Bora is asking, when do you require to consult a hematologist for IDF in a pregnant woman?
Again, a simple MCV, MCH is so important. You know, the hemoglobin level is low. MCV is this, MCH is this, reticulocyte count is this. And if there is a history of bleeding, dyscreasis, hemoglobinopathies, whatever, they should be referred to a hematologist because sometimes the microcytic. This is another sign with the patient's perhaps the slide is there. Get the peripheral smear done properly, and that gives us so many things in a simple peripheral smear when to refer this patient to a hematologist.
And CBC report is very important to evaluate the anemia.
Very important.
Right. Ma'am, I could say wonderful session, ma'am.
Thank you so much.
Yeah, now many questions we have taken, and now I would like to request our faculty team members like Anil sir, Nikhil sir, and Deepak sir, just for give vote of thanks.
Thank you so much.
So thanks, Nakul. Thanks, Samir, Anil, Shrikant, Deepak, and entire team for having the most eminent speaker of the country, speaking with our team members. Ma'am, I would like to sincerely thank you, for joining us today. I can see from the other side that more than 800 team members are listening you live, and the way you have enriched us, it's really, really wonderful. We were more talking about FCM for, pregnancy, third trimester, and all. But the way you have expressed that in surgery, it is another very important point, which it helps patient. Yeah, it changes the quality of the life of the patient, which is really important and a great take home for all of us. And ma'am, team Emcure, we all know that Dr. Kavita Bapat is not just the most eminent speaker of the country and the world, but she is also going to, she is electing for Foxy presidentialship and results are expected to come. So ma'am, you have not talked about it, but I really want your important message for our team members, which you want our team to speak. They will be happy to talk and go forward with the doctors. So anything on that, because you talk enough for FCM.
Thank you so much. Your thoughtfulness and thought-provoking ideas are always good. I need a simple support from heart. Just speak out for me. That's more. Thank you so much.
So, ma'am, certainly the entire team is talking about you, and we'll be happy to see you being a president of Foxy, and we are confident you will be. Yeah.
I'm
So-
blessed to have all of you in my life. Thank you so much. Thank you
Thanks
so
a lot.
Thank you so
Thank you very much. We really, your prestigious, your time means a lot to all of us, and a lot of knowledge enhancement for the entire team. Thank you very much.
Thank you so
Anything from Anil, Shrikant, Samir, if I missed anything. Anil?
Thank you, madam, for the wonderful session. And one question would like to ask, madam, what is the best hemoglobin report from FCM in your practice, madam? That is the last.
What hemoglobin rise? What is asking? What
What is the hemoglobin rise you could get from FCM in your practice?
Yeah, it's good. It's almost up to 3 in 21 days. It's really good. Really, somebody can ask me then how we can repeat FCM, and how this is question not being asked by you people, but I'm telling you, we can repeat FCM even after 120 days, because the cycles of RBC goes in a 120 days. So we can again repeat it. So nothing to worry about. Even after, if the patient has been delivered and we have given at the 37 weeks of FCM, and she delivered in the 38, 39 weeks, if she has a PPH, then when we can repeat it, we can again repeat it within 21 days. That's another point.
Thank you. Thank you a lot.
Thank you so much.
So thank you very much, ma'am. And a lot of best wishes. We'll be looking forward to have your sessions again, ma'am.
Thank you so much. Anytime for you. Thank you so much.
Thank you so much, ma'am, and all the best.
Thank you so much. Thank you so much. Can I leave?
Yes, thanks a lot.
Thank you.
Thank you, and
and
thanks a lot.
Thanks.
I request Sagar, please stop.
Thank you, Vijay. Thank you.